Thank you all so much for being here with us. We know it's lunchtime on a Friday, so please don't hesitate. If you have your lunch with you, eat it. We are all friends by this point. We know each other well, so enjoy. And I just wish we could share over the screen. Unfortunately, we can't. So, because sometimes people are eating things that look so yummy. I'm like, oh gosh. Um, and yeah, look at, oh, Dr. Gibson's got her uh, snack she's taunting us with. Verna's like, man, hers is really good. Uh, so, okay. Well, thank you all for being on. I feel like we've had a little bit of time pass, but I think a lot is happening. So I'm grateful that we're able to regroup, circle back, and touch base with each other. Um, and Misty, I know you've sent us an agenda. So I just want to first ask if we have any new people, if you want to introduce yourselves. I see couple of friendly faces that I'm so glad are on. I don't know about Rachel, if you'd want to introduce yourself and tell us a little bit about yourself, what you're doing, and why COCM is relevant to you and your organization.
Yes. Hey guys, I think I've met most all in here, but it's been a while since I've got or been able to jump on. Yes, I'm here with White River Behavioral Health, and I'm now their director of their behavioral health programs here. And we have a COCM program. I think we've been about 7 years. And I think we're in like 14 clinics. So yeah. I'm a big
Awesome.
fan of collaborative care and have been since I've been working in the hospital and since I have been a part of it. So it's a great program.
We are so glad to have you on and to see you, Rachel.
Yeah, it's good to be here. It's been a while. I used to jump on these every month, but I think it's been about 7 or 8 months. So
Yay! Well, we're glad you're back. I just thought we haven't seen you, so it would be nice for you to introduce, and we're glad you're here.
I'm glad to be back.
Well, so I first let me ask, does anybody have any announcements or things that they want to share or let the group know?
I sent something out on the listserv. I could share it with this group if they didn't see it. We did a really nice little article with the IPA group in Western New York, and they did a really nice job being sustainable and showing some good outcomes in the first couple of months. So if people hadn't seen it, then I'll put a link in.
Yeah, that will be awesome. And
Great.
Verna, I have to give a shout out. Yesterday you shared a video. It was a short
Oh,
video
yeah.
where we were talking about ADHD, and I started watching it. I didn't get through the whole thing, but it was great. And let me just say, he was so engaging, high energy.
Really great. Yeah. And so that actually, just as so people know, we had our psychiatric consultant in one of the other SAMHSA project practices, do a little video to help engage providers. And so he did a video on summertime and medications for ADHD and sent it out. And he did a wonderful job on it, but it actually tripled the referrals that week that came in from the providers. And so I sent it out as like a, hey, this is a really good thing to have your psychiatric consultants do, send it out to providers. So yeah. And we're going to be sharing a bunch of other videos. We just did one on interviewing for like managers that I'll be sending out probably over the weekend, like an interview guide for someone to hire a care manager for the first time. So those will be going out on the listserv, and then you could just save them. They're out there, people can use them.
Oh, wow, awesome. Those are such great resources. I was thinking about you last night as I was watching the video, getting ready for bed, just because sometimes so many things are coming through that listserv. So cool stuff.
And I think maybe for people who are not Collaborative Family Healthcare Association members, I think she's talking about the CFHA
Yeah.
listserv.
Thank you, Tisha. That's true. People might wonder, well, where is all this cool stuff going? Any other announcements or things people want to share with each other?
I have a question. Does anybody else remember what article, and it might have been in the Bowman Family Foundation, and they were saying that collaborative care management can be a solution to mental health parity struggles.
Oh, yeah.
That Bowman Family?
Yeah, it was actually came out, it was a settlement with a union, but it was a really nice parody document. I think I have the link. I know I have the link. I just have to find the link. But yeah.
'Cause I saw
Um,
an old something that was talking about the Senate discussions about mental health parity, and Anna Ratzliff gave testimony to the
yeah,
know,
that was some
US.
time back. Um, yeah, I'll send the link that I can find for that parody.
Thanks, Verna.
Mm-hmm. Thank you.
If there's anybody that doesn't know Verna, then you just saw, if you need to know something, she's going to have an article on it.
And here comes Sarah.
I just put the link to the full report in the chat. And let's see if I can.
I
There
have
was a
the link. I just found it also. I'll see if I can put this in the chat. This is actually the summary about what the fund will do, which is nice for like sort of a parody
There you go.
summary. Yeah. Oh, it's a little over the words. Let me see if I can.
Yeah, I got it too. I had too many words in the chat. I reached the limit.
Yeah.
Appendix A is the PDF that I just put in is really what you want. The full report is really, really, really long.
But I have no doubt Dr. Gibson will dissect the full report and give us a report next month.
Yeah, I put the 6 things in there that are just helpful to think about for parody. That's what you were talking about, Patty. I think so.
That's awesome. One question that I have, and I don't want to get us too sidetracked, but I did go to the National Council's webinar they had, maybe it was a month ago, with their framework. They're calling it their Chi framework, so it's their domains. And I see you shaking your head, Verna. They were referencing how, where collaborative care could fit in. Do you have any thoughts or
I do.
insight? I'd love to
Yeah.
hear.
So Oklahoma actually picked that for their SAMHSA grant to do the framework. And here's my 2 cents. If you're going to do collaborative care, we know a ton about implementing collaborative care. Why go down a rabbit hole, right? Like, why go have this long document with all these steps and all these nuances? Like, it just feels like a distraction. So, I don't know. That's my
That's your-
solid. And then you got to pay a lot of money for consulting. But unless you want to take yourself through it.
No, that's helpful. I was just curious if they were, I don't know, trying to use that framework to show
to show changes in levels of integration. So I work a lot of those projects, and it's like we went from a 2 to a 3. And then you can write in the grant report, all of our practices had an increase because they went from a 2 to a 3. So I'm not saying that it doesn't have a good place in time by any means. You know, there's probably a National Council lightning bolt coming at me right now, but the like if you're going to do collaborative care, then do collaborative care. Like we know what works for collaborative care. We know how to implement it. We know how to train people, right? And we could do that.
Okay. So that's not a necessary component in your opinion.
No.
Sounds good. I don't know if anyone else on the call has had any thoughts as you listen to the National Council and are reviewing this.
And again, it has an absolute place in time. Like if sites aren't integrated at all and they're thinking about integration or they're thinking about, then absolutely it's got a utility. Like there's no question about that. Like it's, you know, thoughtful, it's all put together, but like for collaborative care in particular, I think, you know, maybe not.
Yeah, just kind of thinking more broadly on BHI and if someone was just getting into this. Okay. Cool. Just a question. Sometimes, you know, I have these questions swirling around as I go to these webinars and I'm thinking about how do we fit different pieces in these boxes. So thank you, Verna. That's helpful. That it's out there, it's a tool, but it's not a
It
necessary.
is. Yeah, it's kind of replaces the iPad. If people are familiar with that tool, this is like a farther, which is much better. Like they definitely did a much better job, you know?
Yeah. Okay. Awesome. Well, we can, I don't know, we can get to our updates. So David Jones isn't able to make it today. He's had a conflict, so he won't be here. But Tisha, we can turn it over to you and get some updates on what's going on at UAMS.
Sure. I was wondering, so I had to put together a presentation for another group, and it has some kind of preliminary results from some of our stuff. So I thought that I would share that today, especially since we got a little bit of time. If that's
Yeah.
okay with everybody, if you want to be bored with preliminary UAMS results.
No, we want to see them.
All right. So let me share my screen. So please interrupt me, say words, unmute yourself. I don't want this to be like a lecture. Um, so basically, just want to start out with kind of like zoom out. Sometimes I feel like we get in the weeds and we don't zoom out to figure out why we're doing these things, and kind of, especially to kind of give maybe some of the newer or people who haven't been on in a while kind of an idea of like what our goals are at UAMS and why they are what they are. So, as we all are aware, oh, are you seeing my slides?
Yes.
Yeah.
Okay, good. It wasn't like red around it, so I was making sure you guys are seeing my slide. It says mental
Yeah.
health needs in Arkansas.
Yeah.
Okay, okay. Just want to make sure. So we all know there's a high prevalence of mental health needs all over the country, and in Arkansas, there's no different. Approximately, a quarter of people in Arkansas are diagnosed with depression or mental illness annually. We have high levels of need in youth, and we don't have a specific Arkansas estimate, but about 4% of people meet criteria for PTSD. We all know that we have needs for mental health care. Over half of our uh, counties are mental health professional shortage areas. Wait times for psychiatry, I can't get like an exact estimate, but what I can look at and see is it's about 2 to 6 months And I think that's probably pretty generous for some of our areas for psychiatric care. For example, I know in Pine Bluff, we have a clinic in Pine Bluff, and their community mental health center has just basically said, we're not taking any new people right now. We're too full. So some of our
That was
areas, I
my
think it's,
question. Sorry,
go ahead.
is the wait time specifically within the UAMS system or Arkansas in general?
No, this is research, like based on
Sorry, yeah.
Arkansas. Yeah, no. In at UAMS, it's all over the place. It varies with PRI depending on how when people have openings or not, and PRI, which is the Psychiatric Research Institute, and Walker Family is our outpatient clinic. They only see people who are within a 30-mile radius of UAMS Central. So, like our regional programs don't, their patients can't access unless it's an emergency and they're going inpatient. So, does that help answer your question?
Yes, thank
So, the
you.
best estimates that I can get generally is 2 to 6 months, which we know varies from person to person and place to place. And about 9% of Arkansans are uninsured, with about 30% of adults, at least 30% of adults, saying that cost is a major barrier to engaging in mental health care. And we know that there are disparities between rural and urban areas as far as the higher rates of mental illness and suicide in rural areas, fewer providers, longer travel distances, limited telehealth access. So we know with our patients, some of our rural patients have a hard time accessing telehealth due to their equipment, their broadband access, feeling that it's safe and secure to do so in their own home. XYZ, we experience lots of barriers every day to people engaging in telehealth. And then cultural stigma and just barriers to accessing that are related to kind of beliefs around mental health, what it is and what's effective for it. So it's kind of the stage we live in. Preaching to the choir, we all know true integration includes a true continuum of care. So really accessing people at the population health, generally before they're sick and while they're doing well, and educating people in all areas of how to be healthy and how to take care of themselves when they show up in primary care, which is where we do, the whole continuum of care, and, recognize things, treat things. And then obviously specialty care, where we, really get into very specific issues. If you think about like medical care with specialty care is where we do surgeries and, treat very complex specific uh, disorders. It's a little bit different in mental health care, I would say, that we found that we can treat um, a lot of mental health issues in primary care, and that specialty care isn't necessarily needed, although it's very important as far as like inpatient care, people who need you know, uh, intensive outpatient care and specific needs. So at UAMS, our solution to having these problems in Arkansas is to train the next generation of primary care providers through our robust training. So we have behavioral health faculty in all of our residency clinics. We have rotations and didactics in behavioral health, and our goal is to have training for all our primary care residents in clinics that have robust integrated behavioral health. So not only are they getting the classes and the didactic information, but then when they're seeing patients, they have access to robust integrated clinics. And what we have decided to do is to have our integrated care solution include both the primary care behavioral health model of integrated care and the collaborative care model. And I'm not going to go into a lot of detail about that because I'm preaching to the choir here. Most people know what these two things are. But we decided to do that for a lot of reasons, but one being that we want to be able to treat and support as many of our patients as possible. So I think about this as primary care behavioral health allows us to have someone in the clinic available in the moment, able to treat a wide range and identify a wide range of issues. They are those faculty that do didactics and teach are right at the elbow of our resident physicians, and they also help with more whole patient population and help with the chronic medical condition issues that show up in our clinics. So we have those, and then we also want to have collaborative care, which is we all know what collaborative care is, so I'm not gonna belabor that. But have the psychiatric consultant, the behavioral health care manager that can work with specific groups of patients that we want to help support in getting better and treating them to target for anxiety and depression. We also use collaborative care for supporting diagnostic uh, clarification and help to bridge to specialty care for patients who are kind of spiraling and can't get them in somewhere within a short time frame.
Hey, Tisha,
Yeah.
this is interesting. Who was this presentation for? Because like you're saying, people on this call understand it and are proud y'all are doing it, but where did you get to spread the word?
Yeah, so we got a presentation accepted to this STFM, the Society for Family Medicine, the Teaching of Family Medicine, and Dr. Carletti did the presentation last week
Okay.
in Salt Lake City. I was supposed to go, but we couldn't find a hotel that UMS was willing to pay for me to go to. So, and I had already done a lot of traveling, so I wasn't really willing to throw a fit and
How well
do
was
it.
it received at that meeting?
He isn't back yet, so I don't know. I'll talk to him when he gets back from the conference to see how it went.
Because just a question to the group. This is a great idea, being able to present to the family medicine, that's the teachers of family medicine. You know, after all this time of watching the challenge with getting implementation, I'm wondering if the key place is getting the PCP clinic and leadership on board. Do you think that's the issue? I mean, the place that we can make a difference?
Without question. I mean, that's, yeah, the primary care leadership is absolutely critical.
No, it seems kind of obvious, but it's like people get off track and saying the problem is the payment. And we've spent a lot of time, trying to get Medicaid in all the states to pay. But even some of the states or where other payers are paying, people still aren't taking it up. And so for a while I was like, I've got to fix the payment. And now I'm realizing we got to get the primary care docs on board and their leaders.
That's such a great point. I just wanted to add real quick before we go on with that. One of the things that I think is really cool, and we just heard yesterday on the East Arkansas coaching call, was they're in the process of hiring their second BHCM. It's been a little bit of a struggle. They had they had two BHCMs for maybe 6 months or so. One was and she got her LCSW, and so she left. And they've been in the process of trying to hire this new BHCM. And yesterday I was asking them about their candidates, when they thought they would have a decision, how the interview process was going. And here is kind of that golden nugget that you all are talking about. It was when they said, you know, Kim, Dr. Giles is in these interviews with Dewana, who's their behavioral health director. And she said, I know Dr. Giles likes this model when she's explaining it and selling it to the candidate and telling the candidate what a great opportunity it's going to be. We know she has buy-in. And I thought, oh my goodness, I cannot be more excited that their primary care physicians have bought into the point they're able to explain and sell this to new people. So that was a cool thing.
I'd like to preface it by saying, out of all of the physicians, she was the last one that we thought would be explaining the model to. She was not happy that we were coming in, so that was a huge win.
It's a testament to you guys' work.
And just following up, what are you finding is the most successful way to convince leadership? I mean, that was part of our CFHA, CoCM SIG conversation, but how
For
to
me,
convince, or anybody. I know people and other folks are also implementing. And Rachel, you too, like y'all are in 14 clinics.
Yeah,
What's making it work?
we do telehealth in some of them, so I mean, I think what you guys said with with the provider buy-in is the biggest key. There were some clinics that we were kind of out of sight, out of mind, and that was a lot slower because they would be like where their office was positioned was not close, so that was kind of problematic. But just continuing to kind of round and remind and all of those things.
Yeah.
at UAMS, it's a constant. It's just, we have so many clinics, and then, leadership is there are many, 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 many leaders. So having Dr. Coletti on board is nice, and he's a champion. Sandra Meredith Neve, who's the nursing director, she is a champion. She's really supportive, and then we have kind of we have different levels of interest and support depending on what your clinic you're talking about. And then, we have medical directors, we have training directors, we have faculty, and then we have residents, and the residents, rotate every 3 years, and every year they have a different kind of focus. Sometimes they're in the hospital, sometimes they're in the clinic. And so, we have this huge system of hundreds of doctors, and each one of them is kind of on their own journey academically and in their training world and with their patients. And we have got lots of competing interests, like A1Cs and hypertension, and all of these metrics that we're tracking, and that are depending on what time of the year it is, and who's going to pay what's the focus of the month. And so I think for me, we're incredibly lucky to have leadership that's really invested and interested in behavioral health and our programs and what we want to do. And at the same time, it's a constant push to keep it at the forefront. Not because people don't care, but because there are, dozens and dozens of competing interests in the moment. So that's kind of I don't, my entire, life of my job is trying to stay out in front of people and, keep things going and building processes. I mean, I think, one of the things that Berna talks a lot about, and I think is what makes things stick, is whenever you have things that are just built into the process, just it's just part of what you do. And we've got a little bit of that going, and I think it just keeps, you just got to keep at it. And so that's kind of where we are right now.
And you have 5, right? 5 AHECs that are currently maybe more.
Yeah. So that's kind of my next thing. So I'll hop onto that, do conversation. We have this dream and this model, and that is not the screen I wanted to share. Um,
Don't worry,
that
Tisha.
was,
This
that was
happens.
not it. This one. There we go. We have this dream of, these two models coming together into a full, a robust behavioral health integration at UAMS. And then we got this SAMHSA grant, which we are using to move into having collaborative care in all of our clinics. And so this was our timeline. We're right now in this little in middle of year two. And I'm happy because we are where we said we were going to be. We said we were going to be in 4 to 6 clinics by now, and we are in 5. So that makes me happy. Are we rocking and rolling and magnificently in 5? No, but we are in and uh, working into these 5 clinics. So I just wanted to show some of our preliminary results. So this basically just shows based on our registry, our minutes per month. And it shows January 2024 through March of 25. And so we moved from these are about 1,000 to 1,500 minutes per month. And we're now averaging about 4,000 minutes a month. So we have increased our time that we're spending with patients. And this is just our kind of expansion. So at this point, we had a half of a behavioral health care manager, 0.2 of a psychiatric consultant, and then we were in 2 clinics at this point. This is where we got the money and we're able to hire our care managers. We had 2 from this black line to this black line, and then we hired another 2. And so this is where we have 4 behavioral care managers. We were in 3 clinics until about January, and now we've been in 5 clinics since then. So, Sarah, you had a question?
Yeah, at the end where you say 4 BHCMs, are all of those BHCMs doing collaborative care full time, or do they have other responsibilities as well?
These are hired by the grant, so they are doing collaborative care full time. And my hours, so this is controversial, but our behavioral health care managers are bachelor's trained. They are not licensed social workers. And I know that there's a lot of I don't know, controversy is the word, but debate about that. We do have licensed social workers in of our clinics and licensed clinicians in of all of our clinics. The reason why we decided to do that was because it's just impossible to hire more. We can't fill our LCSW clinics right now, spots, and so I just didn't think it was going to be possible for us to hire them, and also for us to be able to sustain it as a system pay wise. And there have been growing pains related to that. And also, we have a magnificent team, and they are brilliant, and they do a great job. We also have a system where it's a little bit different than other systems in that I am basically their clinical supervisor. I sign off on all their notes. I do trainings with them personally. I do supervision with their patients. I'm there. I'm available via text or instant message or phone call anytime they are working. Me or obviously one of my colleagues. I mean, if I'm off work, someone else is available. So they're not operating on their own. I do think it would be pretty difficult to have bachelor's level um, people in those positions just operating on their own. So that is our we have been doing more, which is good news. We're definitely not where we want to be, but
I'm
it's,
curious, Tisha,
yeah.
as far as I know you had it in minutes, but in hours, is it about 70-ish hours. I just
What do you?
divided 4,251 divided by 60 minutes.
Yes, I
I was
guess if
just
you divide it
curious.
by 60 minutes, yeah.
Um, because one of the things, and I know you were on the psychiatric SIG call this week, Dr. Bill Beecroft was on, and one of the things, and I think this is so promising because one of my takeaways was he said we have to really strategically think about how we're utilizing the BHCM if it's going to break even and we're going to bring in enough revenue to pay for the BHCM salary as well as the psychiatric consultant time. So that was my big takeaway as I'm thinking about East Arkansas. How do we consistently get in enough 60-minute billable units, right, of the 9949, 2, 3, or 4 codes in order to pay for the folks?
I think some of
Yes.
that is training, right? And understanding that if the number of contacts that actually are the greatest predictor of outcome and engagement, right? It's not the amount of time, and it's particularly in the first 2 to
Yeah.
3 weeks of care. Like we know this, right? And so you're better to do that front loading in the beginning with multiple contacts in the first week and the first 2 weeks. And then you got to do a really solid pro forma. So at what point, right? And we did this with Tisha. She was my CoCM pro forma guinea pig, right? We did it live, a little risky for both of us,
Mm-hmm.
but that actually knew then where, at what point she was going to be self-sustaining, like how many patients, so that you have that understanding. Like
And
with average, and doing it a little bit conservatively, but
Yeah.
yeah.
And this to me is, I mean, I did this graph mostly like just to show that we've grown and we're increasing. This is not where we want to be. And we've got growth for sure. But to me it's promising that what we wouldn't want to see is I've hired 4 people and we're doing the same amount of work, right? Um,
yeah, no, it's impressive. I see you guys every week improving.
We're trying. So this is just highlights kind of where we are in the state. So the stars are where we have clinics, and all of these star clinics have access to our behavioral health consultants, or the mental health professionals who help with the training and or do the primary care behavioral health model. And then where the diamonds are is where we have is where right now. Collaborative care is. So we're in Texarkana, Pine Bluff, Helena, in internal medicine, which is in our central clinics, and in Batesville. So just kind of shows that we're covering the state, and the plan is to be in all of these clinics in the next couple of years. The other thing that I think is really cool is that, we talked about at the beginning this time to get engaged in care. And so what I did is I took all of our patients that we saw in collaborative care in 2024, so from January to December 2024, and then I looked at how long did it take from that primary care doctor visit where they saw the primary care doctor to they had a meaningful contact with the behavioral health provider. So they got an intake from behavioral health care manager, which subsequently, at least within a week, led to them getting a consult from the psychiatric consultant, or they had a meaningful like behavioral health consultation with our behavioral consultant where they got an intervention. And these are all our collaborative care patients. So even the collaborative care patients sometimes come through our behavioral health consultants. So basically, what it is that the longest it took was 33 days. But almost everyone is within 2 weeks. So this red mark is a 2 week. So it's 0 days to 33 days. This is 0 to 14. So, and this is again while we're implementing. And so some of these outliers were couldn't get a hold of patients, or there was a delay in getting what's the word? Consent. So we're doing better than we were at the very beginning. But I feel like that this is a helpful piece of information whenever we're talking about, like, why do we do these things, right? Like, we know that people, like Verna said, if we get engaged with people quickly and we start doing things, that we know people are going to get better. And so, this shows that whenever a patient is identified by a doctor, and then, we are brought on board, we get to them pretty quickly. Any questions about this or discussion?
No, but one quick question. When did you all start doing the systematic caseload review in your timeline? Because at one point you were doing it with the BHCMs, but then you officially brought in the psychiatric consultant and started doing that formal piece. How long was that into your
So
process?
with Batesville, we've always had, because we've had Dr. Tripathi. So for one of our clinics, we've always had the psychiatric consultants, and we've always done those meetings weekly. So we started in Batesville in it's the summer of 23. And then whenever we brought on internal medicine, and then Dr. Tripathi didn't want to do internal medicine anymore, I started doing those with Khadijah. And then we got Dr. Sokol starting in October of 2024.
Okay, that's what I was thinking
But
about.
most of those, yeah. So yeah. And then I did a couple of patient examples. These may be ones that I have before here. But one, John, a white male in his 40s, presented to his PCP with a previous diagnosis of bipolar 2, but scored negative on the MDQ. He was on Celexa and Lamictal at the time, had been experiencing anxiety and depression symptoms after moving into his parents' house. Very little motivation to do things, seemed optimistic to work on behavioral activation with our care manager. Consent was obtained, and John was contacted within 1 day by the behavioral health care manager, who completed the initial assessment, helped John set goals for his health and mood. His PHQ-9 score was a 25, his GAD-7 was a 17, and 1 day after his initial assessment, his case was reviewed by the psychiatric consultant, and recommendations were given to his PCP. So over 5 months, John had 5 telephone calls with the behavioral health care manager, totaling about 200 minutes of care in 5 months, which is about 40 minutes a month. He saw physically, or not physically, but over video, the psychiatric consultant once over telemedicine to clarify his diagnosis and make medication recommendations. Over those 5 months, his PHQ-9 score went from a 25 to a 3. His GAD went from a 17 to a 2. And he reported improving his diet and exercise and feeling much better, and was applying for work whenever he was discharged. So, to me, this just shows like a quick, like, he was seen within 2 days, he was getting a psychiatric consultation and was getting recommendations to his doctor. And, how many times can you in the specialty mental health world that you've seen somebody for 5 months for a total of 200 minutes, and their scores have gone from severes to lows, right? Like, it's not typical. And we usually don't know, right? It's because we don't keep track of it like this. And then the other one is example, and these are names that I've changed the names and some of the details. So these shouldn't be identifiable. But we had another one who's a really interesting case. He was a white male in his late teens who presented with chronic pain, severe symptoms of depression and anxiety, and difficulty with the relationships. He was really reluctant to talk to our behavioral health care manager, but agreed to talk with her anyway. They got consent, and then he was contacted on the same day as his primary care doctor. and our care manager, completed the assessment and then helped him set some goals. His PHQ-9 was a 19, his GAD-7 was a 21. And then one day after his initial assessment, his case was reviewed by the psychiatric consultant. And due to the complexity of his symptom presentation, he met virtually with the psychiatrist. And the psychiatrist recommended treatment trials or medication trials for obsessive compulsive disorder and depression. And further symptom screening was recommended by his doctors. And 8 days after his primary care visit, he met virtually with the psychiatric consultant, and he was diagnosed with obsessive compulsive disorder, autism spectrum disorder, and was provided with treatment and medication recommendations. And over 3 months, he had 9 telephone calls with the behavioral health care manager and 5 case consultations with the psychiatric consultant, totaling about 365 minutes, about 121 a month, so a few more minutes per month over a shorter period of time. And then his PHQ-9 score went to a 1 and his GAD score went to a 0. And he reported dramatic improvements in his anxiety and compulsive behaviors, which were hand washing. And his mood was observably improved. So those are my examples.
I just have to say, Tisha, for me, the data and seeing the program is consistently growing and increasing is great. But then when you see and hear those specific case examples of patients who might not be getting this care anywhere else, it really shows us the picture of how quickly and how impactful this model could be. And you talked about, in traditional settings, we probably wouldn't see this type of improvement with this short of amount of treatment. So thank you for those awesome examples.
It's one of the great joys of my job is sitting in on these case reviews and learning about these patients and hearing their stories. So it's a lot of fun.
Awesome. Yes. And I have to brag and say I see Tisha weekly, so I get to hear and see all the amazing work and the progress they're doing. And so it's amazing to be in 5 clinics, and here we are a year and a half in. So cool things happening. I'll just quickly, any questions for Tisha? Okay, I'll just do.
Thanks for the discussion.
And I love when we're doing presentations, right? We all know each other well enough that we could ask questions because it makes it so much easier. I don't like to be the presenter on Zoom where I'm the only one. I feel like talking into the box, but that's okay. I just wanted to say, as far as outside of the UAMS system, right now our main site is East Arkansas. And so we've been working with East Arkansas. Really, the first year was a foundational year, setting them up to implement. And just have to say, they are consistently reporting, and I'm seeing the comment come in. You truly are making a difference for our patients is our comment. So thank you for that. East Arkansas, they are at their West Memphis site. That's their only site right now. The hope is that we will be expanding to Helena. And so we anticipate we will be expanding to Helena in July. They currently only have one BHCM that is working with them, but they have consistently been getting 5 or 6 referrals every week, and they're up to low to mid 40s as far as numbers. So it's not Vernus 30, 60, 90, and we're not on that timeline trajectory. However, my hope is by the end of the 5 years, we are at that point. I don't know. That could be a goal for us, Tisha, to try to, I'm like, ooh, 30, 60, 90. We are at 90 days and we're only at about 45 patients. So we're about halfway there, but we have not met the mark of getting to 90. So, but I am really proud of the work they're doing. They're in the process of hiring that additional behavioral health care manager. Their leadership team has really been instrumental in launching this and buy-in. So just wanted, I guess for me, the consistent piece is that we are seeing continued amount of referrals. One thing I just wanted to call out to the group, and I know we only just have a couple minutes and we can table this to next time, but on this week's call with Dr. Beecroft, one of the takeaways for me was we need to be thoughtful about in the beginning of the program, there could be a lot of energy and a lot of education, enthusiasm, and buy-in. But then as the collaborative care model starts going along, we could see a decrease in referrals and a decrease in utilization of the program because people revert back to what they're comfortable with and what they were trained in. And so I just wanted to call that out. We're celebrating lots of successes and we're really early in our SAMHSA grant, but just making it top of mind. And maybe Dr. Beecroft will come on another call, but how do we keep those referrals happening and keep the enthusiasm of the project as it goes along so we don't see decline? So I don't have the answer to that. But I'm sure Dr. Beecroft could probably talk about it, and maybe we could even invite him to this group at some point.
Yeah. I mean, I think in my mind, the way I think about it is how it stays sustainable and you keep it going is that it gets built into the process, right? It's built into the electronic health record. It's built into the workflows. It's just this is when this person has this, and when we identify this, this is what we do. We are not there at UAMS. I don't know if we'll ever be
Yeah.
there. Some days I think no. Some days I have a little hope. But I think unless, or you have like someone whose full-time job is like me, and like me and Kathy just scheduled 5 road trips in the next 3 weeks. So we will be going to Batesville, Helena, Texarkana, Pine Bluff, and doing more sitting in front of people and education, in internal medicine. So, like, I don't know how sustainable that is for like, do you just have someone who drives around and gets in front of people and sits on their lap and tells them what to do? Um, but that's what we're doing right now because what I don't feel like that what we've been doing has been working. So we're trying something new. So I think
Yeah.
it's a combination of all of it though.
That's a great point. Trial and error and being, consistently moving forward. So I guess that's the positive takeaway is, the programs continue to grow. One thing I just wanted to comment really quick, I see Dr. Gibson's had to leave the call, but this past weekend, the Arkansas Psychiatric Society had their conference. And they did have Dr. Laura Sederi come to Arkansas, and she talked about behavioral health integration and CoCM in particular. And she really generated a lot of interest in CoCM. And one of my takeaways was when she started, she said, how many, and this was all psychiatrists except a couple of other allied health professionals, how many people in this room know what CoCM is? And I think I only saw 3 or 4 psychiatrists raise their hands, which was really surprising to me. And so she went ahead and she did a phenomenal presentation. There were also residents in the room, psychiatric residents. And so Dr. Dunn was there. It was interesting to see, but a takeaway for me is lots of educations happening on CoCM outside of the SAMHSA grant and the work that UAMS and ABIN are doing. So please know that that's happening. We're out there, we're pounding the pavement. Every opportunity we get to share about this, we are. Thank you to the Arkansas Psychiatric Society. They did a fantastic job. They also talked a lot about the legislation that has happened around CoCM. And so thanks to them. And what else? I'm going to pause. Oh gosh, sorry, Caitlin. I'm chattering away and I just looked at the clock. I'm going to turn it over to Caitlin to talk about upcoming announcements.
No, it's fine. I can just have Misty send it out. There's nothing new. It's just some upcoming trainings that we have available, and then our videos from the conference are now uploaded on our YouTube. And there was obviously all about COCM. And I know that Dr. Cody's presentation was very well received. We gotten several comments and questions about when his presentation will be available, and it is now on our YouTube channel. And I'll be posting it on our social media too. I just want to comment too, all the work that we're doing with these clinics and talking about internally is important, but I think this also comes from the patients as well. I've been doing integration for a long time, and I think one of the saving graces that helped implement integration, although mine was PCBH, was the patients knowing that you're there and asking for you, right? So if the providers are going to go back to what they're trained in doing, which obviously does happen sometimes, I think on the other side of the continuum, we can expect our patients as we place these BHCMs in these clinics to remember that they're there, and that is somebody that can advocate for them. That is a resource they can use. So maybe if we see it kind of slip sliding back to not as many referrals, we may want to try upping some marketing strategies. We may want to up just putting it in the patient's face a little bit more so they know that this resource is there, because that sometimes can keep our providers honest, if that makes sense. So I think there's a little bit of expectation for the patients to know that that's there too. They have their favorite nurses, they have their favorite providers. Eventually, they're going to have their favorite BHCMs. So I just that is the fear of like the excitement wearing off. Absolutely is there, but I'm wondering too on the other side is like, okay, patients can kind of help with this too, and start asking, what the resource is. So.
No, that's such a great point, Caitlin. Thank you. And takes everybody. And we know this model, the patient is absolutely the most important person. It should be in all healthcare models, and they are right there in the center of that team. So, all right. Happy Mother's Day. I hope everyone has a wonderful weekend, and we'll see you back next month.